So in today's class, we shall discuss antiviral agents, so mainly the agents which act against non-retrovirus. We will have other class about the drugs which act on the retrovirus. So viruses, they are obligate intracellular parasites, and they utilize host metabolizing enzymes and host ribosome for the protein synthesis. And as they cannot make anything on their own, they use their cellular materials of the host to build themselves, and that's why they are called intracellular parasites. So viruses are obligate intracellular parasites, and their replication depends primarily on the synthetic process of the host cell. And virus can be non-enveloped and enveloped, and they have nucleic acid and capsid. So effective antiviral agents inhibit the virus-specific replicative events, or preferentially inhibit the virus-directed rather than the host cell-directed nucleic acid protein synthesis. So they inhibit the events which are replicative events which are virus specific, and they preferentially inhibit the virus directed rather than the host cell directed nucleic acid or protein synthesis, so that antiviral agents can less toxicity towards the host cell. So what is the virus structure? You know this from the microbiology. There is the genetic material. Viruses can have one or two kinds of the genetic material. It can be DNA virus or RNA virus, and RNA viruses, some of the RNA virus which can convert RNA into DNA, they are called retrovirus. And membrane envelope and capsid, it is a layer of the fatty acid coats possessed by many viruses. It is usually derived from the membrane of the host cell, and there are proteins that stick out of the surface of the virus, and they act as a key to recognize the cell to be infected and invaded. So this is the classification of virus. DNA virus. So we shall mainly discuss on the DNA virus like hepatitis B, herpes virus, what is the treatment options. And among the RNA virus, we have dengue fever virus, hepatitis A, hepatitis C, and HIV influenza. And RNA virus contains an RNA genome, DNA virus contains a DNA genome, and virus replication of the RNA virus is by RNA-dependent RNA polymerase or by reverse transcriptase. And DNA virus, it is DNA polymerase. So this is the life cycle of virus, which is very important. And if you know the life cycle and the drugs acting on different parts of the virus, then we can easily remember the mechanism of action of the antiviral drugs. So first step is the attachment of the virus to the receptor on the host cell surface, then entry of the virus to the host cell membrane. Number 3, uncoating of the viral nucleic acid. So first step is attachment of the virus to the receptor of the host cell surface. Look here at the picture A. Next is entry or penetration of the virus to the host cell membrane. Number 3, uncoating of the viral nucleic acid inside the host cell. Number 4, replication, and there is synthesis of the early regulatory proteins like nucleic acid polymerase. There is DNA or RNA polymerase. There is synthesis of new viral RNA or DNA, and there is synthesis of the late structural proteins later. And after this synthesis of these late structural proteins, number 5 step is assembly of the viral particles and to form a new virus particles. And number 6 is the release of the new virus particle from the host cell. So there are different drugs are available to act on these different steps of the virus, so that the drugs can have their antiviral activity. So this is the picture which summarizes different mechanism of action of different antiviral drugs. So viral attachment and entry, that is inhibited by enfuvirtide for HIV virus, maravir for HIV virus, and docosanol for the herpes simplex virus. Number 2, penetration, that is blocked by interferon alpha, mostly used in hepatitis B and C virus. Number 3, uncoating of the virus, that is blocked by amantadine rimantadine, applicable for the influenza virus. Number 4, replication and early protein synthesis, and nucleic acid synthesis, that is inhibited by for the HIV, they are blocked by the NRTI and NRTI, that is the nucleoside reverse transcriptase inhibitor and non-nucleoside reverse transcriptase inhibitor for HIV. Example is zidovudine, lamivudine, nevirapine, etc. For herpes simplex virus, this nucleic synthesis is blocked by acyclovir. For hepatitis B virus, it is blocked by entecavir. Late protein synthesis is the next step, and the processing of the new virus particle, that is blocked by protease inhibitors for HIV. Next, packaging and assembly, and last step is viral release, that is inhibited by neuraminidase inhibitor for influenza virus. So these are the different steps and different agents which can block different steps. If you remember this picture, then mechanism of action of the most of the antiviral drugs become easy. So many viruses infect a specific host cell, and viral infections are self-limiting and require no medical treatment. Example, rhinovirus that cause common cold, they do not require any treatment. Common viral infections such as influenza, mumps or chickenpox are usually overcome by the body's immune system. And some of the virus infection cause serious and even fatal disease, require aggressive therapy. Example, HIV. So this is the viral replication. That's the same picture. Attaches to the cell, nucleic acid and DNA, RNA, that is uncoating then, and virus penetrates cell membrane and injects the nucleic acid into the host cell. Nucleic acid replicates using host cell machinery. So this replication is done by the host cell machinery, and there is formation of the new viral particles, and they are packaged into this nucleic acids are packaged into viral particles, and they are released from the cell. The host cell may be destroyed by this process. So this is the different virus which causes different diseases. So let's discuss the antiviral drugs. So common viral infections such as influenza, mumps, chickenpox are usually overcome by the body's immune system. So antiviral drugs work by either altering the host cell genetic material so that the virus cannot use it to multiply. Example, acyclovir inhibits the viral enzyme. Host expression of the viral proteins and assembly of viral protein is also inhibited. And there is prevention of the new virus formed from the leaving the cell, like amantadine. So antiviral therapy is challenging because often the metabolizing enzyme is similar in the host cell as well as viral cell, and there is rapid replication of the virus makes it difficult to develop effective antiviral. Virus can rapidly mutate and drugs become ineffective, and it is difficulty for drug to find virus without injuring normal cells, because non-selective inhibitors of viral replication may interfere with the host cell function too, and that can result in toxicity. This is the classification of the antiviral drugs. Anti-herpes virus, we have most commonly used drug is acyclovir, valacyclovir. We have famciclovir and acyclovir. They are mostly useful for the cytomegalovirus infection. Also we have valganciclovir, cidofovir, foscarnet, homiphycin. So these are the drugs used against different virus of the herpes family. Anti-influenza drug, we have amantadine, rimantadine, and oseltamivir, zanamivir. Drugs against hepatitis B and hepatitis C. For hepatitis B we have lamivudine, entecavir, adafovir, tenofovir. For hepatitis C we have ribavirin and interferon alpha. Also interferon alpha can be used in hepatitis B also, but as there are multiple options of hepatitis B, interferon alpha is less commonly used against hepatitis B. Then for retrovirus, and these are the antiretroviral, nucleoside reverse transcription inhibitor, example zidovudine, cefovudine, lamivudine, tenofovir. Non-nucleoside reverse transcription inhibitors, nevirapine, efavirenz. Protease inhibitors ends with navir, like ritonavir, atazanavir, indonavir, lopinavir, etc. Fusion inhibitor or entry inhibitor, enfovetide, CCR5 receptor antagonist, maraviroc, and integrase inhibitor, dolutegravir. So these are the antiretroviral, and the first list is for the other drugs which are active against non-retrovirus. Next we have to discuss in brief about the different antiviral agents. First, acyclovir. So look here. So acyclovir is herpes specific. Acyclovir, after entry into the host cell, they are activated first by herpes virus specific thymidine kinase into acyclovir monophosphate, and subsequent steps are done by the host cell kinase. These are called cellular kinase. So first step is done by the virus specific thymidine kinase from acyclovir to acyclomonophosphate, then monophosphate to diphosphate and triphosphate. These are done by the host cell kinase by cellular kinases, acyclovir triphosphate, and this acyclovir triphosphate inhibits the herpes virus DNA polymerase competitively. Okay, and some part of this acyclovir triphosphate is also gets incorporated in viral DNA and stops lengthening of the DNA strand. Thus, there is termination of the DNA, and this inhibition of the DNA polymerase is irreversible. Okay, so acyclovir monophosphate done by the virus specific thymidine kinase, then di and triphosphate by the host cell specific cellular kinase. This acyclovir triphosphate gets incorporated into viral DNA and stops lengthening of the DNA strand, and there is inhibition of the DNA polymerase, that is competitive inhibition. Agents to treat herpes simplex virus and varicella zoster virus infection. Example: acyclovir, valacyclovir, famciclovir. This is the oral agents. Of ophthalmic herpes virus can be treated by trifluridine. There are few topical agents like acyclovir is also used topically. Docosanol, that is the inhibitor, and penciclovir. For intravenous, we have acyclovir also. So acyclovir can be used in oral, topical as well as in IV route. And HSV, that can cause repeated blister-like lesion on the skin, genitals and mucosal surface. Some remain latent, activated by physical and emotional stress. And HSV type 1 is non-genital infection, HSV type 2 mostly cause genital infection. Will normal non-infected host cells be sensitive to acyclovir? Answer is no, because the first step is done by of activation of the acyclovir is done by virus-specific thymidine kinase. So unless there is the cell is affected, acyclovir do not have their own effect. So that's why acyclovir is relatively less toxic to the normal cells, because the first step of activation of acyclovir is done by virus-specific thymidine kinase. So unless it is converted into acyclovir monophosphate, this is ultimately that triphosphate form is not generated. That's why there is less toxicity. Acyclovir clinical use: herpes simplex, herpes zoster, chickenpox, Epstein-Barr virus, IV, oral or topical. Depending on the severity of the infection and the location of the infection, we can use these agents, and it can be used during pregnancy also. And this is well tolerated, and toxic effect occurs in patients with renal failure only. It can cause interstitial nephritis. Other topical drugs for HSV, and also it can cause crystalluria, acyclovir. Other topical drugs for herpes simplex virus, we have penciclovir, docosanol. Docosanol interferes with the viral fusion of the host cell, and if there is ocular infection like herpes simplex virus keratoconjunctivitis, we have trifluridine. Okay. Trifluridine and penciclovir mechanism of action is same like acyclovir. So agents used to treat cytomegalovirus infection, mechanism of action is same like acyclovir, but the agents are different. Like for cytomegalovirus, we mainly use ganciclovir, valganciclovir, foscarnet, cidofovir, fomevirsen. Among them, foscarnet, fomevirsen have some different mechanism of action. So CMV infection occur in advanced immune suppression, typically due to reactivation of the latent infection, and most common it is after renal transplant. And disseminated infection occurs results in end organ disease like tritinitis, colitis, esophagitis, CNS disease and pneumonitis. Ganciclovir and valganciclovir is a prodrug which is converted into ganciclovir. Mechanism is similar like acyclovir, and it has low oral viability. That's why given IV, and it can cause adverse effects like bone marrow suppression and psychosis conversion. Foscarnet is an inorganic pyrophosphate analog. It does not have need to be phosphorylated. So unlike cidofovir, ganciclovir, acyclovir, foscarnet itself is a pyrophosphate analog, so does not have to be phosphorylated. And it is active against herpes 1 and 2, varicella, cytomegalovirus, including those resistant to acyclovir and ganciclovir. So varicella is a chickenpox infection. We can use acyclovir, valcyclovir. Also, we can use foscarnet. It is used also in IV. Direct inhibition of the DNA polymerase as well as reverse transcriptase enzyme, and adverse effect is it can cause nephrotoxicity, electrical imbalance, and some CNS effects. It should be used given during pregnancy when benefit outweighs risk, but it is a very not commonly used agent. Commonly we use those acyclovir, valcyclovir, ganciclovir, etc. Cidofovir is incorporation into viral DNA chain, results in reduction in the rate of the viral DNA synthesis. So mechanism of action is same like acyclovir, and it can cause nephrotoxicity. That's why it should be administered with high dose probenecid and adequate hydration, and otherwise there is chance of more renal damage, and there is more chance of interstitial nephritis. So these are the mechanism of action of all these drugs: acyclovir, ganciclovir, penciclovir. First step is done by virus-specific enzyme, thymidine kinase, monophosphate. Then monophosphate to diphosphate and triphosphate done by the host kinase. And this trifluridine, cidofovir, foscarnet, they inhibit the host kinase too. And after formation of this triphosphate, they are incorporated into viral DNA and cause termination of the DNA chain, and competitive inhibition of the viral DNA polymerase. There is inhibition of the viral DNA synthesis. Okay, so new viral DNA is not formed. Fomifizin, its mechanism of action is different from other drugs. It is an antisense oligonucleotide which specifically inhibits the replication of the human cytomegalovirus. So it is an oligonucleotide and it inhibits the replication of the viral human cytomegalovirus. It binds to the complementary sequence of the mRNA, thus blocks the translation. So other agents block the transcription process. It blocks the translation process because it is an antisense oligonucleotide. It binds to the complementary sequence of the mRNA. So blocks translation of the viral RNA and used in CMV retinitis as intravitreal injection. So cytomegalovirus retinitis, fomifizin is an option. So these are the drugs for the different virus of the herpes family. Among them you have to know in detail about the acyclovir. Anti-hepatitis agents. So treatment for viral hepatitis, there is no specific hepatitis A treatment. Fortunately, the disease usually gets better on its own, and most people who get hepatitis A recover in specific several weeks or months. And persons acutely infected with HIV should avoid alcohol and other hepatotoxic medications until they have been fully recovered. Viral hepatitis B, acute hepatitis B infection does not require antiviral drug treatment. So what is acute and what is chronic? Chronic hepatitis B means when infection lasts for more than 6 months. So presence of HBsAg for more than 6 months is chronic infection. Before that we call it acute infection, and acute infection does not usually require antiviral drug treatment. So early antiviral treatment may only be required in patients with a very aggressive fulminant hepatitis or in immunocompromised patients. For people with chronic hepatitis B, antiviral drug therapy is used to slow down the liver damage and prevent complications like cirrhosis and liver cancer. So hepatitis B, if it is untreated, it can cause chronicity, and chronic hepatitis B infection can lead to cirrhosis of liver as well as it can lead to hepatocellular carcinoma. So we have multiple options. We can use interferon, lamivudine, entecavir, tenofovir, etc. So interferon, which is a family of a small antiviral proteins. Interferon, prepare them as short note. It is a very commonly asked question. So interferon, what is the mechanism of action? Interferons are a family of small antiviral proteins produced as earliest response of body to viral infection. So interferons can be produced by body also. It's a family of small antiviral proteins that can be produced by the body as the earliest response to a body to viral infections. And both DNA and RNA virus can induce interferon, but RNA virus tend to induce at higher levels. Okay. So currently grouped into IFN alpha, IFN beta, and IFN gamma. Alpha and beta are produced by all body cells in response to various stimuli, virus, bacteria, also tumor cells and parasites. And gamma is produced by the T lymphocytes and natural killer cells. And gamma has less antiviral activity. So mostly we use interferon alpha here for the hepatitis infection. Disadvantage is that it has to be injected parenterally. Either it can be induced intralesionally for some tumors, or for most commonly it is used subcutaneous or IV route. And distribution in all body tissues is good except CNS and eye. And pegylated interferon, that is means interferon that is combined with polyethylene glycol, they are modified interferons with improved pharmacokinetic properties. That means they are having better penetration into the most of the tissues as well as longer duration action. That's why it can be dosed less frequently. So interferon alpha, it acts by binding to the membrane receptors on the cell surface. So the host cell which are receiving the or recognizing the virus, infection virus, that is inhibited by this the host cell receptor, they are inhibited by the interferon alpha. Also they induces hostile enzyme that inhibit the viral RNA translation, and that may cause degradation of the viral mRNA and tRNA. So they induce some hostile enzyme that inhibit the viral RNA translation and cause degradation of the viral mRNA and tRNA. Also they inhibit the viral penetration, uncoating, mRNA synthesis and translation. Also they inhibit the viral assembly and release. So different steps of the virus life cycle. If you remember the virus life cycle, then different steps from binding to penetration to uncoating, replication, translation, as well as release and viral assembly and release. All steps can be inhibited by the interferon. And there is enhancement of the phagocytic activity of the macrophages. There is augmentation of the proliferation and survival of the cytotoxic T cells. So these are the mechanism of action of the interferon alpha. This interferon in chronic hepatitis B, how it is act. So this is the first step. First step is entry, then uncoating, then positive strand synthesis, negative strand synthesis, translation, replication, and then maturation of the viral protein from the new viral particles, then activation of the lymphocytes. So all steps can be actually inhibited by the interferon. Okay, so translation is also inhibited, uncoating is also inhibited, the strand synthesis is also inhibited, transcription is also inhibited, and the activation of the lymphocytes that aggravate their action. So what is the clinical uses of this interferon alpha, chronic hepatitis B and C, herpes virus, influenza virus, some types of cancer like renal cell carcinoma, malignant melanoma, lymphoma, leukemia, and age-related Kaposi sarcoma. So for Kaposi sarcoma, malignant melanoma, this can be used intralesionally. Okay. So most commonly used is chronic hepatitis B and C. For herpes and influenza, we have other drugs. So side effects, it can cause flu-like syndromes within few hours administration. It can cause neurotoxicity like seizures. It can cause neutropenia. There is elevation of the liver enzymes, and often it can cause alopecia or hair loss. So where it is contraindicated? If already there is hepatic failure, autoimmune disease, and pregnancy, interferon is not given. So what are the other treatment options for hepatitis B virus infection? They competitively inhibit the hepatitis B virus DNA polymerase to result in chain termination after incorporation into the viral DNA. Okay, so their examples are adafovir, entecavir, lamivudine, telivudine, and tenofovir. So all they inhibit the hepatitis B virus DNA polymerase to result in chain termination after incorporation into viral DNA, and they are to be used in chronic hepatitis B when infection or HBsAg persists for more than 6 months. Lamivudine is a potent nucleoside analog. This inhibits the hepatitis B virus DNA polymerase and both types of HIV reverse transcriptase. So lamivudine has two types of action: inhibits the DNA polymerase of hepatitis B, as well as in HIV it inhibits the reverse transcriptase. It is a prodrug. It needs to be phosphorylated and its triphosphate form before it is active. So just like acyclovir, it also needs to be converted into this triphosphate form. And remember, this triphosphate form, it is entirely done by the host cell kinase from lamivudine monophosphate, diphosphate, triphosphate. Unlike acyclovir, where first step is done by the virus specific kinase, but in lamivudine all steps are done by the host cell kinase. So clinical use: chronic hepatitis B and as well as HIV. It can cause paraesthesia, peripheral neuropathy, and pancreatitis. So whom to treat? Look here. So hepatitis B surface antigen positive, that means if it is more than 6 months, then we may consider treatment. But then also, if HBeAg is positive and the hepatitis B virus DNA is more than 20,000 per unit per ml, and ALT, that is a liver enzyme, it is less than 2 times upper limit of normal, then it indicates low efficacy of treatment. If ALT is less than upper limit of normal, we should observe, and if ALT is 1 to 2 times upper limit of normal, then treat if biopsy shows substantial inflammation or fibrosis. But if it is HBV DNA is more than 20,000, also ALT is more than 2 times upper limit of normal, then treat. Okay, so all chronic hepatitis B virus do not require treatment. If HBV is positive, HBV DNA and is more, ALT is more than 2 times of normal, then treat with any of the recommended agents like lamivudine, tenofovir, entecavir, or interferon alpha. Entecavir and tenofovir are favored drug over earlier generation drug, and pegylated interferon has supplemented standard interferon. So standard interferon is not used. Pegylated interferon, that means polyethylene glycol attached interferon, is more commonly used, and liver biopsy is not needed if HBV DNA and ALT is high. But if ALT is low, then we need to do liver biopsy to show how much is the liver damage, and accordingly we can select if there is already substantial inflammation fibrosis, then we can start antiviral treatment. So lamivudine, and also if HBV is negative, then HBV DNA is more, ALT is more, treat with any of the treatment options. If HBV DNA is more but ALT is not so much raised, then consider biopsy, treat if biopsy shows substantial inflammation and fibrosis. Okay, and if HBV is negative, HBV DNA is also less, ALT is also less, no treatment observed. Okay, so this is the treatment recommendation for the hepatitis B, chronic hepatitis B infection. Lamivudine dose is 100 milligram per day duration until HBAG is conversion. So HBAG, presence of HBAG is an indicator of the active viral replication. So HBAG, until it is negative, we should continue the treatment. And patients should receive a period of consolidation therapy of more than 6 months in Western patients and greater than 1 year in Asian patients after HBAG seroconversion. So even after HBAG seroconversion, we need to treat it for almost another 1 year. Adafovir is another drug, 10 milligram per day, once daily. And next drug are specialty interferon alpha. Dose is 180 micrograms subcutaneous weekly for 48 weeks. This is a standard therapy. So normal interferon need to be injected daily, but specialty interferon can be injected per week. Entecavir is an oral cyclopentanyl guanosine analog. It is also DNA polymerase inhibitor that appears to be most potent for the hepatitis B antiviral and is well tolerated. It is also effective against lamivudine resistant HBV infection. Telbivudine as another option, and tenofovir is an acyclic nucleotide analog and potent antiviral agent. Also, tenofovir has additional effect on the HIV infection because it inhibits the reverse transcription enzyme just like lamivudine. Next, treatment of the chronic viral hepatitis C. So, we wait for 6 months before starting therapy for hepatitis B. But for hepatitis C, most 90% of the hepatitis C tend to get chronic infection. So, once detected hepatitis C, we start therapy. That is the major difference between treating hepatitis B and C. Okay. So, hepatitis B, mostly it is acute, very less number go to chronicity, but hepatitis C mostly go to chronicity. That's why we should begin the treatment early. And if we can begin treatment early, we can recovery is complete now because of introduction of the better drugs. So what are the options? Interferon alpha, pegylated interferon alpha, ribavirin, and directly acting antivirals, also called DAA. So this is the proper mechanism of action of the interferon and ribavirin in chronic hepatitis C infection. So if you remember the interferon, all steps of this binding, protein entry, uncoating, these are inhibited by the interferon. Also transcription, translation is inhibited. So, but ribavirin, they block the IL-4 inhibition of the cytotoxic T lymphocyte, okay, and they inhibit the specific cytotoxic T lymphocyte, and induction of the cytotoxic T lymphocyte actually triggers the apoptosis and inflammation. So, ribavirin inhibit or block the pro-inflammatory cytokines as well as they induce some cytotoxic lymphocyte, so trigger the apoptosis of the infected cell. So, this is the mechanism of action of the ribavirin, okay, and this is the action of the different drugs which act as also called directly acting antivirals. So HCV is an hepatitis B virus is a DNA virus, whereas HCV is the RNA virus. So interferon is acting better on the RNA virus. And apart from this HCV RNA, there is translation into different polyproteins. They are called NS3, NS4A, NS4B, NS5A, NS5B, and this is the formation of the polyprotein from the HCV RNA. And for its activity, they need to be converted. They need to be cleaved by some protease. Some are called NS3, NS4A protease. Some are called NS5B protease, NS5A protease, etc. And after that, there is formation of the new HCV RNA, and they are released from the cell. So, if you can block this protease enzyme, then there is for prevention of the formation of the new viral particles. So, there are multiple protease inhibitors are there. Some are called NS3, NS4A protease inhibitors like boceprevir, sinaprevir, telaprevir, etc. Some are called NS5B polymerase inhibitors like dasabuvir, sofosbuvir. Pegylated interferon alpha, you know that. Ribavirin, they may inhibit the HCV polymerase, and mostly they inhibit the formation of the inflammatory cytokines, and also they activate some T lymphocytes to cause apoptosis. NS5 inhibitors are also called daclastavir, lepidasiran, valpatasvir, etc. So names are difficult. Remember this NS5 inhibitors, NS5B inhibitors, NS3, NS4 protease inhibitors. Some of the commonly used drugs are sofosbuvir, boceprevir, daclastavir, ledipasvir. These are the drugs used in hepatitis C virus infection, but they are used along with ribavirin or interferon alpha. So ribavirin is a guanosine analog mechanism, phosphorylated to triphosphate formed by host enzyme, Inhibited the RNA-dependent RNA polymerase. Viral RNA synthesis is inhibited and viral replication is also inhibited. But adverse effect is hemolytic anemia and conjunctival and bronchial irritation. Sulfosulfide is a product of the urine analog. Active form competes with the urine diphosphate UDP for incorporation into HCV RNA by NS5B polymerase, and it is used in combination with sinoprevir, daclastravir or evapirin. Not metabolism inducer or inhibitor, but it is a substrate for the efflux transporter of the P glycoprotein. So some of the as it is a substrate for P glycoprotein, it can cause efflux of some of the drugs from the virus cell, a virus infected cell, and that may cause drug interaction. So active form competes with the UDP for incorporation into HCV RNA by NS5B polymerase. So it is a, if you see the picture, sulfosulfide is a NS5B polymerase inhibitor. Okay. So one group is protease inhibitor, one group is polymerase inhibitor. So that is called, after formation of this protein by the protease, the polymerase enzyme helps in the formation of the mature viral particles, and this sulfosulfide prevents that maturation of the viral particles by polymerase activity. So first step is protease inhibitor, where polyproteins are cleaved, and after this cleaving, polymerase enzyme helps in the assembly of this protein and formation of the mature viral particles. So these protease inhibitors block this first step, polymerase inhibitor blocks the second step. Okay, and sulfosulfide is a polymerase inhibitor. Ladipasvir is inhibitor of the NS5A, that is also a polymerase inhibitor. Not detail is not required for treatment. How long treatment is required? If it is there is cirrhosis, we continue therapy for 24 weeks, or if it is without cirrhosis, you can continue the therapy for 12 weeks. That can convert into the sustained virological remission into 96 to 99%. So other DAA or directly acting antivirus are daclastravir, sinoprevir. Other options also we can have ritonavir, gazapravir, elbasvir. So these are the difficult name of this HCV, but remember this sulfosulfide, ladipasvir, this introduction of this, and if we can use them for ribavirin interferon alpha, with ribavirin interferon alpha, then ribavirin sulfosulfide combination or this interferon sulfosulfide combination, that can cure the hepatitis C virus very rapidly within 12 to 24 weeks, compared to previous duration where treatment was often very long. Okay, so this is therapy for treatment naive patients. The HCV genotype is also important to select which therapy is needed. There are multiple genotypes. Some have poor prognosis, some require longer therapy from 1 to 6. Look here. So commonly the sulfosulfide is very commonly used combination. So ladipasvir sulfosulfide used for in genotype 1A, sulfosulfide ribavirin used in genotype 2 and 3, ladipasvir sulfosulfide used in genotype 4, also ladipasvir sulfosulfide for genotype 6, sulfosulfide ribavirin and pediatric interferon alpha, all that need to be used in genotype 5, which is relatively difficult to control. Okay, so duration of therapy is 12 weeks for cirrhosis without cirrhosis, 24 weeks without cirrhosis. Next, anti-influenza agents. So we have discussed hepatitis B and C treatment. We have discussed herpes virus treatment. Now we are discussing anti-influenza agents. So influenza virus strains are classified by their core proteins A, B or C, and species of origin avian and swine. So influenza is the only strain that causes pandemic. It is classified into 16H and 9N known subtypes based on the surface protein. So H is called hemagglutinin and N is called neuraminidase enzyme. They can infect a variety of the animal host. Avian influenza subtypes are classically highly species specific, but they can also on rare occasion cross the species barrier to infect the humans and cats. So this is the structure of the influenza virus. There is a proton channel on M2 which helps in the entry of the virus. There is hemagglutinin, there is neuraminidase, there is nuclear export protein, polymerase enzyme, and matrix protein M1. So virus of the H5 and H7 types may rapidly mutate within poultry, have recently expanded their host range to cause both avian and human disease. H5N1 virus, they first caused human infection in 1997, became endemic in some areas since 2003, and it is transmissible from person to person. So classes of the influenza antiviral drug, how we can inhibit the infection of the influenza so that it doesn't spread. There are M2 antigen inhibitors, amantadine, dimantadine, and also neuraminidase inhibitors. M2 antigen inhibitor is which causes the entry of the virus, and neuraminidase inhibitor helps in the release of the mature viral particles. Amantadine, dimantadine, they block the M2 channel of the virus and inhibit the uncoating of the viral RNA within the infected host cell. Okay, so amantadine, dimantadine you have read in Parkinson's disease. It blocks the M2 channel of the virus particle, inhibit the uncoating of the viral RNA within infected host cell, thus prevents their replication. Okay, so uncoating is the initial step. So penetration and uncoating both are inhibited by this amantadine and dimantadine. Activity is against influenza A only. Amantadine is more active than the amantadine, and it can cause some insomnia or GI disturbance. Otherwise, it is well tolerated. Okay, so this is the structure, how influenza virus life cycle happens. So first there is binding of cell surface, hemagglutinin. Then there is endocytosis. There is endocytosis of the cell, and there is M2 protein, which causes actually the uncoating or helps in the uncoating of the viral particles inside the host cell. Then there is RNA replication, and protein synthesis is done by structural protein is formed. There is assembly, and after that there is release, and this release is done by this neuraminidase enzyme, which is blocked by separate group of drugs, that is oseltamivir. The marked increase in the prevalence of the resistance to both agents in clinical isolates over the last decades has limited their usefulness. So this amantadine dimantadine is now less commonly used due to widespread resistance. So we have to use this oseltamivir or zanamivir for better activity. These are the neuraminidase inhibitor discovered in 1999, and they are chemically related but have different routes of administration. Interfere with the release of the influenza virus from infected to new host cell. So there is inhibition of the release. So uncoating is inhibited by this amantadine. M2 protein is inhibited, whereas oseltamivir, by inhibiting the neuraminidase, they inhibit the release of the new influenza virus from infected cell so that they are not infecting the new host cell. They competitively reversibly interact with the active enzyme site to inhibit the neuraminidase activity, and also they destroy the receptor found on the normal host cell recognized by the viral hemagglutinin. So hemagglutinin and neuraminidase. What is the purpose of these two proteins? Neuraminidase helps in the release of the virus proteins, and hemagglutinin recognizes the host cell. So host cell receptor recognizes the hemagglutinin of the virus, and they destroy the receptors found on the normal host cell recognized by the viral hemagglutinin. So they cause dual action. One is they inhibit the neuraminidase enzyme, also they inhibit the host cell receptor for the hemagglutinin, which is responsible for the recognition of the virus particles by the host cell. Okay. So activity, both influenza A and influenza B virus are killed by this oseltamivir and zanamivir. Early administration is crucial because replication of influenza virus peaks at 24 to 72 hours after the onset of illness, and it is approved for patients 1 year or older, whereas zanamivir is approved for the treatment of 7 years or older. So oseltamivir administered orally is the prodrug. It is activated by the hepatic esterase. It is widely distributed throughout the body. Rates of resistance to oseltamivir among H1N1 virus have risen abruptly and dramatically worldwide. It may be associated with point mutation in the viral hemagglutinin or neuraminidase gene. Zanamivir, it is administered by inhalation. 10 to 20% of the active compound reaches the lungs, and the remainder is deposited on the oropharynx. And as a result of this, due to this inhalation route, it can have some adverse effect related to that can cause cough, bronchospasm, and reversible decrease in the pulmonary function, and transient nasal and throat discomfort. So oseltamivir, zanamivir, you should remember that is the neuraminidase inhibitor. Also, they inhibit the host cell receptor for the hemagglutinin. Antivirus agents against COVID-19. So multiple drugs have been tried. Remdesivir was developed as a possible treatment for the Ebola hemorrhagic virus and Marburg virus infection. It is a nucleotide analog, specifically an adenosine analog, evidence to have broad spectrum activity against the single-stranded RNA virus. So current research trials has shown that it is effective against certain key enzymes of the SARS-CoV-2 that causes the COVID-19. So this is the mechanism of action of the remdesivir. Not going to detail. They metabolize into active form known as this GS441554. They interfere with the action of the viral RNA-dependent RNA polymerase enzyme. Favipiravir, that is another antiviral medication used to treat influenza in Japan. They also inhibit the viral RNA-dependent RNA polymerase enzyme. So these are the drugs which we also for antiviral drugs we have also there is a variable success of the ivermectin and doxycycline against this COVID infection, but remdesivir and favipiravir they are exclusively used as antiviral agents. So from this class, remember this mechanism of action of the acyclovir, their adverse effects where they are used. Also uses of this ganciclovir for CMV infection. Also, and remember the drugs used in hepatitis B virus, hepatitis C virus, mechanism of action of the lamivudine, tenofovir, mechanism of action of the interferon, that is very important. What are the adverse effects of the interferon, mechanism of interferon, and drug mechanism of action of the oseltamivir, mechanism of action of the amantadine. These need to be remembered, and treatment for the hepatitis B also is also needed. Hepatitis C treatment, whom require treatment, that is also needed. Prepare these questions and antiviral. Does it? We complete the antiviral drugs which are active against the non-retrovirus. In next class we shall discuss antiviral which act against the retrovirus.